Thank you, Ruth. So hello, my name is Chris Hopson. As you've heard, I'm the Chief Executive of NHS Providers. Just in case any of you haven't come across us before, we are the membership and trade organisation for the 233 acute community mental health and ambulance trusts and foundation trusts. Great to see such a packed room and great to be here in Kent. So one of the things that I think I can probably do in a way that perhaps not everybody can is give you a national perspective, as Ruth has said, and thank you, Ruth, for those very kind words, much appreciated. We are a national organisation and we talk to all of the different STPs and can therefore give you a sense, I think, about what are these organisations, why have them, what kind of progress are we making, what are people focusing on in STPs? What are STPs finding difficult? And to be frank, there's quite a lot that people are finding difficult. And then just give you some reflections on perhaps what, talking to all 44 STPs, what we think the keys to unlocking success are. So hopefully this won't be a surprise or news to you, but there's no doubt that, certainly, again, when I joined the NHS about 5 years ago, one of the things that came across to me really, really quickly is that the existing model of health and care provision is rapidly breaking down. So a sense that we've got quite a fragmented system, and again, all of you, I'm sure, have kind of come across those cases where people have had to interact with vast numbers of different sets of the health and care system and simply have a completely fragmented and unjoined up experience. I was listening to some of the Q&A earlier on, a real kind of sense that we have a health and care system that is absolutely kind of focused on treating illness as opposed to prevention and encouraging health and well-being. I think perhaps slightly more controversially, but a real kind of sense that we currently have a system that is very much kind of based on acute hospitals. I have a little parlour game that I play. One of the great privileges of my job is the ability to go around and visit, and I must have visited now, must be, I should think, about 60, 70 acute district general hospitals. And one of the questions I always ask is, so what percentage of people currently are in your beds who are medically fit to discharge and ought not to be there? I've still not found anybody yet who's given me a percentage that is lower than 30%. So I think a real kind of sense that at the moment we have a model of care where we've got a whole bunch of people who are in hospitals who ought not to be in hospitals. I think a real kind of sense that we've got a service that is oriented to 20th century disease patterns in terms of, things where if you've got something wrong with you, we'll whip you into an acute hospital, do something to you, whip you back out again, and all will be fine. And it's very clear as we've now got these kind of complex multiple comorbidities where we've got people who've got diabetes, who are recovering from cancer, recovering from heart attacks, etc. Whatever it is, you're much more the expert at this than I am, but a real kind of sense that actually disease patterns are changing and people are living with multiple long-term conditions, and we perhaps don't have a health and care system that's set up to do with that. I think one of the things that we're all grappling with and are all finding kind of quite difficult is a real sense of too much variation in outcomes. What we spend quite a lot of our time talking about is a real kind of sense of very rapidly rising demand, but actually we're going through a 10, 12-year period, potentially longer if the economy gets a Brexit shock that people are speculating might happen, where actually the funding is massively undershooting the demand in the growth in demand and cost. So again, a figure that we use a lot is cost and demand in the NHS are going up by on average 4% a year, and we're in this 12-year period where funding has only grown by 1% a year. So not entirely surprising the gap is beginning to show. And also a real kind of sense that we're actually, being a bit more positive, on the edge of some really interesting technological developments that we really need to kind of take advantage of. So genomics being a very good example where you can absolutely see in 20, 25 years' time, if we do it right, healthcare will have been transformed. So, why have STPs? And the answer is we do need to move to a different way of providing healthcare. So we need to integrate physical, mental and social healthcare, GPs, community care, hospitals, social care services, mental health provision. We do need a much greater emphasis on preventing ill health and supporting our citizens to improve and maintain their own health and well-being. We do need to move care closer to home and keep acute care only for when it's needed, and that will involve us shifting resources, redesigning services and repurposing buildings. We do need to support our citizens to manage their own more prevalent long-term conditions. We need to improve outcomes and reduce the current very wide variation in outcomes. we also need to increase efficiency and productivity whilst trying to slow down increases or even reduce demand for health and care services. And we need to make much better use of IT and quicker take-up of new innovations and best practices to support these changes. So a real, as I said, a real kind of change in the way that we provide health and care. So why have STPs? Well, the answer is that they're actually the way in which we are now intending to successfully deliver these new models of care. And what that requires is local, previously quite disparate local systems. And don't forget, we've spent the last kind of 10, 15 years, in a sense, or perhaps even longer, saying to people, really focus in this kind of quasi-market approach that has been put forward in Provider Commissioner Split and then also in the Health and Social Care Act. What we're saying is actually, no, it's not about being a brilliant institution pulling up your drawbridge. Actually, it's about a local system coming together, changing what that system does, altering how you work together, and working towards a different and new future. And that is what STPs are there for. I would point out that one of the problems we have is that there is a danger of overloading STPs, and I wanted to be very specific about this. And again, we'll give you our perspective. Our colleagues in other places, NHS England, NHS Britain, might have a different view, but certainly what we consistently hear coming back is a real kind of sense of we are asking STPs to do a huge amount. So not just plot that future towards a more integrated new models of care, but we're also asking people to fully close what looks to us to be, and to quite a few STPs to be, a very large-looking 2020-2021 NHS financial gap. So the initial genesis of STPs was to complete a plan that effectively said, how would you close a 2020-21 financial gap? I think it's fair to say that in some places STPs have tended to slightly, if I don't mind the use of the word, degenerate into a kind of, a very tightly focused financial gap closing exercise, which actually you might argue slightly cuts across the idea of how we meant to be plotting this brand new integrated future. I think for some people, and again, I think there's a real danger of this, and again, there's more stuff in the HSJ in the last couple of days, which is in this theme, which is that there are some people who would actually like to reproduce, you might argue, some of that kind of pan CCG and trust quasi-strategic health authority kind of financial and performance delivery and accountability structure. So if you are sitting at the centre, to be fair, it's really quite difficult to hold the NHS to account, because you've got to hold 233 different providers and whatever it is now, about 212, I think it was last time I looked, at CCGs. And there is a bit of a kind of enthusiasm in some places, particularly for those who wish to be administratively tidy, to say, wouldn't it be great to just have 44 people to hold to account for performance and delivery? And wouldn't it be great to have those people crossing both providers and CCGs? The reality, of course, and we'll come on to this, is that actually the law still says very, very clearly that it is the individual institutions that still remain responsible for performance and delivery accountability. So, yes, great to kind of do this forward-looking kind of planning, but just be careful about trying to turn STPs into some kind of pan-individual institution performance and accountability mechanism. And then there is a bit of a sense in terms of STPs trying to be the new unit and the new footprint for planning and delivering everything. So I think this thing I saw in HSJ this morning as I was travelling down on the train was, I think you're all about to be given targets for new GP levels of GP recruitment. Again, I make no comment on that individually, but all I'm saying is that we just need to be careful about making the assumption that every single thing has to go through the STP footprint. Again, you tell me, our kind of sense is that the NHS has always worked on a number of different footprints. And as we go around STPs, what a number of people say to us is, and again, I think the same is happening exactly here, is that actually when you're kind of trying to look at, for example, accountable care organisations where you're vertically integrating GPs, social care, acute care, community care, mental health, actually the STP footprint is probably too big. And that in most places where we're talking to STPs, there are a number of accountable care organisations or systems that sit underneath the STP footprint. So in that sense, for accountable care, moving to it, actually the STP footprint is too small. Equally, when you go and talk to people and say, when you're looking at, for example, big regional specialisms across, large acute hospitals, actually, and you're talking about, for example, looking at more of a regional approach to a particular specialism, what you quite often hear is actually the STP footprint is too small. What I meant to say on the accountable care one is that the STP footprint's too big. So a real kind of sense that we just need to be really clear about what we're asking each STP footprint to do, and there will be some things that it absolutely will be appropriate for the STP footprint to do, but there actually will be some things that should be done on a smaller footprint, and there'll be some things that are done on a larger footprint. So let's not just pretend that everything should go through a single STP footprint. So how are STPs getting on? You'll have your own view about how your particular STP is getting on. Here's our view of what we think is happening in STPs nationally. We have a phrase. Our phrase is, if you've seen one STP, you've seen one STP. And the reason we say that is because we think there is significant variation between STPs. And interestingly, that variation is growing fast. It seems to us, and I think you've probably heard from one this morning in terms of Dorset, there are a few that are really rocketing ahead at pace and moving to become accountable care systems or organisations. Don't get hung up on the definition. Our view would be that if you try and identify what is it that are enabling those people to really rocket ahead, it's usually the fact that they've got long-standing good relationships and system working, and or they've had a head start. So again, I mean, I don't know Dorset brilliantly well, but having talked to some of the providers down there, it's pretty clear to us they've been at this system working STP type game for at least 3-4 years. They were already pretty well embarked on a consultation plan about how all of Dorset was going to work together before STPs actually ever arrived. And it's also clear to us that in some places the footprint in terms of its size and shape is right, but there are other places where actually the shape and the size of the footprint is really quite difficult. So there is one footprint that's got 2 million population size and has got something extraordinary, like every time they meet as an STP, one person from each organisation, I think they've got 45 people sitting around the table, which is somewhat difficult. It seems to us then right at the other end, in a sense, there are a small number who are stuck and struggling of STPs, where the size and the shape of the footprint or the number of the players in the footprint is difficult, where there have been poor relationships in history, including some tensions and jockeying for position between institutions and all sectors, and also a kind of real sense that in some places it's really difficult to get out of a day-to-day focus on some really difficult performance issues. And we know that the service is under, I mean, certainly people say to me, probably the greatest pressure it's been under for a generation, and sometimes it's really difficult to kind of put that to one side and actually say, let's plot a glorious new future together. So I think in some places, there is a real kind of sense that that combination of real pressure on day-to-day performance meets the size of the 2021 financial challenge is again weighing people down. There's a lot of people in the middle. So if you ask me what are people doing in STPs, it seems to us that all STPs do vary on their areas of focus, but there are some common themes. One of them is definitely, what does it take to work as a single system, not a collection of individual institutions? And how, therefore, do we move to new ways of taking decisions? And what are the new and different ways of making stuff like money and kind of contracts work? So as I said, the way we've all been encouraged to work, the way the system is structured, the way the incentives work, the way the performance management work has been individual institutions. And we are in the middle of this really interesting period where we're clearly moving away from individual institutions to systems. The law is stuck because it can't catch up, because we can't change the law. But what's interesting to us is that a lot of people are spending time in STPs saying, so how do we, recognising there are some legal constraints here, how do we move towards working as an effective system? What does that mean about how we make our decisions? A lot of people are talking about, as I've said already, vertical integration in terms of probably at a kind of sub-STP footprint. And again, you'll know how your footprint divides, but quite a few. So one I know very well, Berkshire, Oxfordshire and Buckinghamshire. There's a Berkshire accountable care system developing. There's an Oxfordshire accountable care system developing. There is a Buckinghamshire accountable care system developing, which I visited 2 or 3 weeks ago. So, but a lot of people are saying, how do we bring together fragmented health and care services. And what's also quite often happening in those places is it's about moving care closer to home. So how do we shrink the acute sector and swap primary care at scale meets big bulked up community services? How do we move away from this acute model to one that's much more focused on primary care at scale and community services? How do we centre care on more capable prevention and upstream focused community hubs? If there's one sort of set of buzz concept or buzzwords at the moment, a real sense that community hubs in those accountable care systems are becoming really, really important. How do we develop a whole population health approach and stratify according to risk? In other words, actually a key measure of actually how do we use the GP list system to then say who is at most risk of needing to have some form of early intervention and how do we target them? How do we redesign the hospital specialist consultancy service to support that? How a very strong focus virtually everywhere we go on redesigning the frail elderly pathway as probably a key driver of current acute volumes. And then how do we explicitly target trying to reduce demand on the acute sector to allow bed closure and resource allocation? So again, lots of people struggling with it. If we're going to move care closer to home, how do we actually free up acute capacity to enable that to happen? The other thing that I think is happening is quite a lot of horizontal integration. So again, I was interested talking to Paul when he was giving me some briefing about the fact that you're looking at rationalising the number of CCGs and perhaps moving towards a single accountable officer covering a number of CCGs. That's again a very common trend that we're seeing across a lot of STPs. Lots of people talking about reconfiguring acute services. So, for example, moving service lines between neighbouring DGHs and reviewing the provision of specialist services. A lot of talk about how do we share back office services. A lot of actually how do we, in a time of real resource scarcity, really focus resource on frontline care and actually take it out of non-frontline care. So coming into the home straight, what are STPs finding difficult? So our kind of sense is that in lots of places, this whole thing of getting the relationships right so you can work effectively as a system is really difficult, and particularly where there are lots of different players or where there have been some long-standing historic rivalries. And I think there is a real issue here for us all about how do you match that STP system idea to that long-standing legal and cultural focus on individual institutions. And again, I think we hear a few STPs absolutely getting stuck on the governance stuff, in a sense, understandably, but actually you're not going to make much progress if you're spending your whole time talking about, well, what's the governance structure to allow us to come to system decisions? Actually, you need to get on and make some system-level decisions. I think getting, as I've already said, people are some places finding it difficult to get their head round the footprint conundrum, i.e. this idea that all roads do not lead to the SDP. I think there's no doubt that every time, again, we go out, that people are finding how do we properly and fully engage the GP community is something that is really difficult. I mean, people thought that maybe federations were going to be the answer, but our kind of sense is that actually GP federations, there are different federations. Some of them, absolutely, makes sense to engage with the federation, and you can be confident that then you are engaging with the individual practices. But our view would be in the vast majority of cases, actually the federation, if you talk to the federation, you're just talking to the federation, you're not actually talking to the practices. I think some people are clearly stuck on and are finding it difficult to move beyond the focus on the pattern of acute services. Quite often in STPs, it's the big burly acutes who tend to dominate the discussion and actually and they have a long conversation, often a good conversation about how to allocate acute services across the DGH sites. But to be frank, if that's the conversation is all about, we're missing a very, very big trick about actually how you, as I said, move care out of acute services into close to the community. I think people are finding it difficult. I've not found anybody yet who's got anywhere near fully closing the financial gap. So I think a real kind of sense that financial gap closure issue is really difficult. And again, I think something that people are finding difficult is developing a true focus on prevention. So, what are the keys from what we've seen so far to unlocking SDP success? Here are 5 thoughts I'd share with you as I go around the country and identifying what I think it seems to us to be working well and really driving successful STPs. The first is the quality of relationship between all the key players in the local system. it seems to us the STPs who fully got their GPs, local authorities, CCGs, hospitals, community and mental health providers, and I would also actually add the third sector, fully involved in their plans are the places that seem to us to be really motoring. Secondly, that there's an unequivocal willingness to prioritise the needs of patients and the system at the expense of the individual institution, which can be really, really difficult given those governance structures, given the culture, given the way that things work. But the places that are working really well are the places where the leaders in those areas are saying, I understand I've got some individual institutional requirements here, but actually I'm going to really prioritise the system. For us, I think there's thirdly a really ruthless focus on a small number of practical priorities. And what I'm saying is, if you actually, in my view, and again, I hope I'm not being too rude here to our colleagues at NHS England, but if you followed every single thing that the STP was asked to do, you'd be trying to boil the ocean. So our view is that the STPs that are succeeding are the ones that are really saying, okay, these are the 3 or 4 or 5 things that really matter to us. They really matter to our population. That's what we're going to really drive on. And then what people then do, fourth point, is they're driving rapid on-the-ground practical improvements in the chosen priority areas. They're not just trying to build a grand plan in those areas. They're actually saying, let's get on, let's do some stuff, let's build confidence that actually this is all going to work. Let's do some practical things quickly to make some changes. And the final thing is, it's actually, for me, it's about pragmatism meets continuous improvement. And what I mean by that is, let's just get on and try some new stuff. And there are plenty of places where it hasn't really worked particularly well, but let's just learn the lessons of that and then basically do something new and improved based on that, the lessons that you've learned from that initial bit. But a real focus in those last 2 points about actually not just focusing on trying to do the grand plan, but actually getting on with some stuff, making things different, changing care outcomes, and then effectively learning the lessons from that and then carrying on to continuously improve the changes that you've made. Hope that's been helpful. That's a quick tour d'horizon of what it looks like from our perspective. Very keen to hear any Q&As you've got after my colleague from Health Watch England.
Very good. Thank you very much.